So my job is to discuss the use of endoscopic ultrasound for pancreatic cystic lesions. We will not be talking about drainage of peripancreatic fluid collections. That talk will be on Tuesday. Acknowledgement for one of my colleagues, Dr. Singh, and Dr. Deprez for some of the slides. The cysts come in different shapes, configurations, communication or no communication to the duct, with masses or without masses inside the cyst. It's not easy just to look with one imaging modality and figure out what we are dealing with, but my job here today is hopefully help you make a differential diagnosis, narrow it down with the information that we can get with different modalities, including endoscopic ultrasound. So the prevalence of cystic lesions using a CAT scan data is about 3%, although some studies using MRI have reported a prevalence of up to 20%. Of course, that will depend on the age of the patient population as prevalence increases with the age. A lot of these, or most of the cysts these days are being diagnosed incidentally. We're doing more imaging, and our imaging modalities have gotten better. So we're diagnosing more cysts. And of course, there's a wide spectrum of benign, pre-malignant, and malignant lesions. There are two key questions. One is, what type of cyst are we dealing with? Because that will dictate therapy and surveillance. And is there any evidence of malignancy in the cyst? And of course, that should be our primary question. So I'm gonna show you a lot of slides on when we look at cysts, how can we narrow down the differential, or how can we pinpoint the exact diagnosis. In terms of morphologic classifications, this is how we classify cysts. You see the unilocular cyst, and then you see macrocystic. The macrocysts, which has septa inside it. When you see a cyst like that, usually it's either an IPMN or an MCN, mucinous cystic neoplasm. Then we have the microcysts. This is usually a serous cystic adenoma, and we can see a central scar in the middle. And of course, we cysts with mural nodules and mass component. And so this is the morphological classification. In terms of different kind of classification, epithelial and non-epithelial cysts. So we have the epithelial neoplastic, which means they either are cancerous or they can potentially turn into cancer. So this is what neoplasms are. And these include the cysts that we usually talk about, the IPMN, the MCN, ductal adenocarcinoma with cystic degeneration, neuroendocrine tumors with cystic degeneration. To the right of that, you have the epithelial non-neoplastic cysts, like the lymphoepithelial cysts. So they have epithelium, but these are non-neoplastic. And to the bottom, we have non-epithelial but neoplastic, basically lymphangioma and the sarcomas. And of course, pseudocysts, which are non-epithelial and non-neoplastic. To make it easier, these are the cysts that we usually deal with on a daily basis. We either classify them as cysts with very low or no malignant potential, and these are the pseudocysts, which has no malignant potential, or the serous cyst, which has very low malignant potential. And then we have those with malignant potential, and these are the solid pseudopapillary neoplasm, pancreatic neuroendocrine tumors, mucinous cystic neoplasm, and intraductal papillary mucinous neoplasm. So usually we start with CT and MRI, abdominal imaging. This is how cysts are discovered. Sometimes we can tell by CT or MRI what type of cyst it is, based or if the cyst has evidence of malignancy. If it does, then these patients go straight to surgery. If we figure out the diagnosis on CT and MRI, we'll put patients in surveillance programs. EUS FNA is mainly used when diagnosis is unclear, or if we perform the procedure, there's a chance that management is going to change. So here are classic features by which we can pinpoint the exact diagnosis of cysts. So we've all seen this, a serous cystic adenoma. We can see the microcysts, and we can see the central calcification. These microcysts are seen in about half of serous cysts. So not all serous cysts, you're going to see a microcyst. It's usually in half of the patients. Some of these serous cysts are unilocular, and it's very hard to differentiate just by looking at them if that's an IPMN, MCN, or a serous cyst adenoma. But this is the classic feature. We can also see these discrete foci with bright signal intensity on T2 weighted images on MRI, and this is also diagnostic of a serous cyst. So this is the classic features. What about location? Mucinous cystic neoplasm, 97% are in the body and tail, and more than 95% of patients are females. So if you have a male patient with a cyst in the head, it's a very low chance that this is going to be an MCN. So this helps us narrow the differential. And now, what about number of cysts and communication with the duct? Patients with IPMN, commonly in 21 to 41% of cases will have multiple cysts throughout the pancreas, and we can see a direct communication between the cyst and the main duct, and this is usually how we can differentiate an IPMN from MCN. The MRI and MRI MRCP is very sensitive and specific for diagnosing IPMNs. CT, you can see less sensitivity and specificity, but still okay. What about features of malignancy? There are high-risk features, and there are worrisome features. So it's very important to differentiate and understand these two terms, high risk and worrisome, because this dictates how we manage these patients. The high-risk features are pancreatic duct 10 millimeter or larger, and we have a solid component that's enhancing. So again, enhancing solid component. In half of these patients, we're going to find either a high-grade dysplasia or cancer. These are the worrisome features. And so if you have a dilated duct, but less than 10 millimeter, if you have a solid component, but it's non-enhancing, and now you can see to the right a cyst wall that's thickened, or if you have a mural nodule that's, again, non-enhancing. By no means I want you to look at all these slides, but just a couple of features here. In terms of history, we know that serous cystic neoplasm are associated with von Hippel-Lindau syndrome, and cystic neuroendocrine tumors are associated with multiple endocrine neoplasia. In terms of calcification, serous cyst neoplasm, as we already talked about, they have a central scar. You can see calcification. Solid pseudopapillary neoplasm, sometimes you can see calcifications, and sometimes in neuroendocrine tumors. With MCN, if there is a calcification in the wall, this makes the cyst a high risk for malignancy. In terms of epithelium, it's important to also understand what kind of epithelium, because sometimes with FNA we can obtain epithelial cells, and that can help with the diagnosis. You can see IPMN and MCN are made of columnar epithelium, while serous cysts are made of cuboidal epithelium. So how good are CT and MRI in helping us figuring out what type of cyst we are dealing with? You can see multiple studies that I mentioned, but the summary is the CT is accurate in telling us what type of cyst it is in about half of the patients. Accuracy of MRI is a little bit higher when we sum up the literature, but they're both, I think, around 50 to 60%. So this is in figuring out the type of cyst. What about using abdominal imaging to figure out, does the cyst have malignancy in it? Is there a solid component? Is there a mass within the cyst? And you can see, again, multiple studies. The largest we published in 2013. And also, the CT is accurate in 60 to 86%, and MRI 78 to 91% in diagnosing malignancy within the cyst. So abdominal imaging helps us, but it's far from perfect. This is, we looked at, this is a study we published in Pancreas in 2013. We looked at the additive value of EUS after abdominal imaging for pancreatic cyst. You can see here in these 42 patients, the CT did not detect a cyst, but EUS did. In some patients, it was vice versa. And with MRI, there was a significant number of patients where cysts were not seen on MRI, but seen on EUS, very few patients vice versa. But if you looked at the additive value or incremental yield of EUS after CT and MRI, it was 36% after CT. So you get additional information in 36% of patients and 54% with MRI. The second study I mentioned here, it showed that combination of EUS and MRI improved sensitivity in determining the type of cyst and identification of cancer. So it looks like EUS does have good additive value. This here I decided to put this very interesting study, again, value of EUS, of performing EUS in patients with cyst. The study from Japan, very interesting study because they followed the patients prospectively for a long period of time while patients are undergoing EUS, ultrasound, MRI, CAT scans at frequent intervals. And basically the 3- and 5-year rates of IPMN, concomitant pancreatic ductal adenocarcinoma. So this is not IPMN-derived cancer. This is cancer developing away from the cyst. And it developed in up to 9% of patients at 5 years. And EUS was significantly better than all other imaging modalities in diagnosing IPMN concomitant pancreatic ductal adenocarcinoma during follow-up. And also, I didn't mention, EUS was initially better than CT and MRI in diagnosing malignancy, IPMN-derived malignancy. So we also take another important point from this study is that these patients with IPMN, it looks like they have a field defect, so they can develop pancreatic ductal adenocarcinoma at increased incidence in the remainder of the pancreas. So when should we do an EUS? When it alters management. And this is the Tanaka Criteria, published in 2012. There are a lot of criteria these days, including recent AGA recommendations that confused everybody. But I think this is still what holds these days, the Tanaka Criteria, which I think they're the best criteria. So first we look, does the patient have the very high risk features, the high risk features, which are enhancing solid component, the duct that's very dilated, 10 or more, or if the patient has a cystic lesion in the head with jaundice, so it tells us there is an invasive nature within that cyst. If these are found, we don't need to do anything, these patients go straight to surgery. If these are not found, then we look at the worrisome features that we talked about, the thickened wall, a solid component that's non-enhancing. We look at a dilated duct, but not to the degree of 10 millimeter. If these are found, then we perform EUS. If EUS ruled out any worrisome features, or if these worrisome features were not found even before we did the EUS, then we put the patient in surveillance program. If EUS confirms these high-risk features, like a mural nodule that turns to be a cancer, then we send these patients to surgery. In terms of if we put patients in surveillance program, let me summarize here. So if the lesion is less than 1 centimeter, we do imaging every 2 to 3 years. If it's 1 to 2 centimeter, then CT and MRI yearly for 2 years, and if it's stable, then we can lengthen the interval. When the lesion is between 2 and 3 centimeter, we do EUS in 3 to 6 months. We lengthen the interval after the lesion is stable. Consider surgery in young, fit patients, because of then that way they are not committed to long surveillance. Similar recommendations for lesions that are larger than 3 centimeters. So in the past, we said if a lesion is larger than 3 centimeters, then the patients go to surgery. And now we don't. We put them in surveillance programs, but strongly consider surgery if the patient is young and fit. So we perform FNA if, for example, this serous cyst here, if we can diagnose the serous cyst, so that helps us say it's benign, leave it alone as long as the patient is asymptomatic. When the diagnosis is unclear, when there is this possible mural nodule, or when there is a clear mural nodule. About mural nodules, there is 3 features. One is irregular edge. So to the left of the screen, this lesion has irregular edge. To the right of the screen, this has a smooth edge. This has iso or hyperechoic echogenicity. To the right, it is hypoechoic. And the third feature, to the left, is there is absence of rim. To the right, there is a rim. So if you have all these features are present, then your EUS is 90% accurate in saying that the left lesion is cancerous and the right lesion is mucin. So we look at all these to try to differentiate if that is that really a mural nodule or is that actually just mucin. We can also perform contrast-enhanced EUS to help us with that, or puncture that component, and usually if it's mucin, you can either suck it or it moves around. EUS-FNA is very safe. We'll talk about that on Tuesday. Usually we send primarily the fluid for CA and cytology, sometimes for amylase, but amylase does not have that much use. Cytology, its sensitivity is 54%, so in half the cases it gives you information, but when it's positive for cancer, it's usually positive. For cystic fluid amylase, I want to draw your attention here. There's no difference between mucinous cystic adenoma and mucinous cystic adenocarcinoma. Also, amylase this is the same with MCN and IPMN. So this is the amylase level. So the amylase level has the best use to figure out if the lesion is a pseudocyst or not a pseudocyst. If the amylase is less than 250, then there is 98% chance that this is not a pseudocyst. This is from Bill Brugge. He looked at the use of CEA with a cutoff of 192 to differentiate a mucinous from non-mucinous cysts. So if the CEA is higher than 192, the accuracy for predicting a mucinous lesion is 79%. Really not that good. So do not go with CEA in terms of confirming the diagnosis. It suggests, but it does not confirm the diagnosis. The higher the CEA, the higher chance of malignancy, but we do not operate based on CEA levels. If we increase the cutoff for CEA to 400, then it becomes more specific for the diagnosis of a mucinous lesion. So if a CEA is above 400, there's more than 95% chance actually that this is a mucinous lesion. And this is again from Bill Brugge. We can look at the accuracy at the bottom line, 50% for just looking by EUS, 50% with cytology. Looking at the CEA, it's better, it's 79, but still not perfect. The last few slides, I'll be finishing in a few minutes, is about markers, biomarkers inside the cystic fluid. So all this data that I have presented suggests that we're still not that good in pinpointing an accurate diagnosis. But now we're moving to biomarkers. Initially it started with this red path, looking at loss of heterozygosity, KRAS mutations, and DNA content. Initial studies were good, but then if you look at this last study at the bottom from Muhammad Al-Haddad from Indiana University, largest study, 286 patients, the sensitivity of these markers was only 50%, so really not that good. At Hopkins, we have a lot of smart people working on these biomarkers, and they developed this GNAS mutation that you can see here. And I'm going to skip straight to that GNAS because of lack of time. You can see that the GNAS mutation, you can find it in IPMN, but you don't find it in any other tumors, whether it's MCN, solid pseudopapillary neoplasm, or a serous cyst adenoma. And they looked at GNAS and KRAS to differentiate IPMNs from serous cystic adenoma in a small initial study, and it had a very high sensitivity and specificity. And then what we looked at is if you give secretin to stimulate pancreatic juice, and then you go with your EUS scope and suction the fluid coming out of the pancreatic orifice, you can actually look at these mutations just by suctioning the juice from the duodenal lumen, and they were able also to detect these GNAS mutation in pancreatic juice. So maybe one day we can just suction this juice and it can help us differentiate what type of cyst and possibly the malignant potential of the cyst. A lot of people working on this with very promising results the last time I heard about it, but I think it's going to help us with managing these patients. Thank you very much.